Well, thanks a lot, Dr. Iannitti. I think, this is a real eye-opener for most people. If you're going to go to a physician to treat your neuroendocrine disease, you certainly want somebody who can treat it that well. And you'll see that with all the speakers today. But I thought that was really an interesting presentation. So anyway, who was watching TV at about 5 to 7 this morning? Huh? Were you watching CBS? Did you see me up there? Oh, you see that? Marianne and I were out there. That's what we do. We're just trying to spread the word about neuroendocrine tumors, and we were lucky enough to come here and get on TV this morning. So that was kind of fun. But anyway, I'm just giving them some time to get the next presentation ready. Okay, we're ready. So our next speaker is an oncologist who works with Dr. Iannitti, and his name is Dr. Reza Nazemzadeh. And he said we have permission to call him Dr. Reza. So please welcome Dr. Reza.
Good morning, everybody. Glad to be here. Hope you're enjoying the conference so far. Dr. Iannitti is always very entertaining. That's hard to follow him, but I'll do my best. Things have changed since I started my oncology career. I can remember 12, 13, 14 years ago when I was a fellow in training at Vanderbilt, and I worked with Dr. Ken Handy, who some of you might know, who was the guy back then treating these cancers at that institution. And it was always very frustrating to me in clinic because we would see a patient, they would have an operation, and then we'd give them sandostatin, and that was it. We really had nothing else that we could offer them. And it was kind of depressing, to be honest with you. So it's really wonderful what's transpired in the last 10 years as far as surgery, interventional radiology, and systemic treatments. We have a lot more options coming our way as well. And I was asked to come spend some time with you guys and talk a little bit about what the future holds. So I saw this the other day, and I thought it was an apropos slide to put on there because I really do believe better things are coming. I guess another anecdote, when I started going to cancer conferences, I was interested in neuroendocrine tumors, and I would always go to the sessions. I would look for sessions for neuroendocrine cancers. I would look for poster presentations, and I'd spend a lot of time looking for them and really couldn't find anything. Now you go to various meetings during the course of the year, and there's more and more time devoted to research on this on a scientific bench level, as well as in clinical trials. So again, better things are indeed coming. So I wanted to talk about two trials that have recently been completed or are ongoing, and then I'm going to go through various drugs that we are currently studying and give you a little bit of information on those things. So I'll just jump into it. So this is a drug, cabozantinib, that has already been approved for use in two malignancies, medullary thyroid cancer and kidney cancer. It's an interesting compound. We think it works by inhibiting something called c-MET and also VEGFR2. What's a little bit different about this drug compared to some of the other drugs used in neuroendocrine cancers is that it targets MET, and there's some evidence that MET may be important in treating in the development and progression of neuroendocrine tumors. So there was a trial that was done looking at 61 patients with progressive, well-differentiated or low-grade carcinoid tumors or pNETS. So most of these patients had prior therapy. The pNETs had everolimus or Afinitor, sunitinib, which is Sutent, and temozolomide or Temodar. The dose was 60 milligrams, which is the dose that's used in treatment of kidney cancer as well. And it's a well-tolerated dose. So the trial was, like I said, divided into pNETs and carcinoids. And just to review the pNET part of it, again, this is a small trial with not a whole lot of patients, but interesting results. So a partial response, evidence of shrinkage of the cancer, was seen in 3 patients out of 20. Doesn't seem like a whole lot, but you have to remember, in this disease, we don't typically see a whole lot of shrinkage. We see stability with Sutent, with Afinitor. So the fact that we actually saw shrinkage of the cancer is a big deal. Stable disease in 75%. So 15 out of 20, 2 patients we didn't really, they weren't able to follow. And here's the big thing. Median progression-free survival was 21.8 months. So the median time frame where the cancer got worse was over 20 months. So if you look at the trials for that got Sutent and Afinitor approved, for Afinitor it was only about 11 months. So it's almost double that. So pretty impressive early results. And the side effects of this drug are pretty manageable. It's a drug, like I mentioned, that were given for other malignancies, and patients in general tolerate it at least as well as Afinitor and Sutent, for sure. So the carcinoids, a few more patients, and to me this is a little bit even more interesting because we had partial responses again in 15%. So I can't tell you how impressive that is because carcinoids, more so than pNETS, with other treatments, we don't see tumor shrinkage. So the fact that we got shrinkage in 6 out of the 41 patients is a big deal. And this is what certainly got me excited. Stable disease in most of them, which means no growth, and progression in a small number. So the median progression-free survival was over 30 months, which in general carcinoids they grow slower, so you would see a more prolonged progression-free survival. But to me, that's very impressive. So why did they only have 61 patients? Well, the company that was helping the team run the trial ran out of money, so unfortunately. But clearly, this drug, this compound, to me, shows evidence of very promising activity in both carcinoids and pNETs. But you have to remember, this is a preliminary study, very small amount of patients, so you can't really draw too many conclusions from it. We need to do a bigger study, more patients, to confirm these very interesting results. Again, we get better at this disease, at treating this disease with clinical trials. So moving on to another trial that is actually currently in progress using temozolomide, or Temodar, versus Temodar plus Capecitabine, which is the CAP-TEM combination that you guys probably know about. And this is in pancreatic neuroendocrine tumors. So CAP-TEM we know is active based on multiple small trials in well-differentiated or low-grade neuroendocrine tumors, excellent response rates in small early-phase studies. The CAP-TEM regimen looked better in pNETs rather than compared to non-pNETs, so that's why they're focusing on pNETs in this trial. And in general, we think that the active agent in the CAP-TEM combination is the temozolomide. So we're trying to tease out that a little bit more. Obviously, if we have one drug instead of 2 drugs and get the same effect, it's better because there's less toxicities. So a randomized trial, randomized phase 2 study is being planned with a lot of patients, 145 patients. If you look at the prior CAP-TEM trials, there are very, very few number of patients, certainly less than 50 patients. So this is a big trial. This is very ambitious. It's going to take a while to get it accrued. But again, we need to get people in these trials. Another interesting thing about this particular trial is that they're looking at the effect of something called the MGMT gene, which can potentially predict the response to the Temodar. So we actually look at MGMT when we're giving Temodar in brain tumors. We think that if the cancer expresses this gene, it would make it less likely for the tumor to respond to the Temodar. So if we have a patient that has a cancer that has high levels of expression of MGMT, then it wouldn't make sense, and we can save somebody the pain and suffering on being on a treatment that probably won't work. So that's an important thing that they're also investigating in this trial. And I think a very, very ambitious trial. It's going to take a lot of work to accrue that many patients. So then I'm going to switch gears a little bit and talk about other drugs. And, it's really, as I was going through the literature, I was frankly surprised at how many drugs are being tested in this disease. And it's really, really encouraging. It's a lot of reason for optimism. So I'll talk about these drugs that are already approved in other malignancies. So axitinib is a drug that's approved for kidney cancer. Another name for it is Inlyta. It works similar to Sutent, and it's used most often in kidney cancer patients who failed Sutent. So I think it probably has a similar activity as Sutent and Afinitor. The great thing about axitinib is that it's much better tolerated than Sutent. So if you guys have ever been on Sutent, you know how difficult it can be to take it for a long period of time. So that's currently being investigated, and if it works out and we see that it has activity, it may be a very attractive treatment option with pretty good tolerance. Pazopanib, or another name for it is Votrient, is a drug that's approved for use in kidney cancer as well as soft tissue sarcomas. Similar activity, similar mechanism of action as Sutent, an anti-angiogenic, or affecting the blood supply of the tumor. Pretty well tolerated. So I'd say it's about like Sutent, being currently investigated. And again, I think that early phase studies with pazopanib did indicate some signs of activity, and now bigger studies are being done to confirm that response. Lenvatinib, another anti-angiogenic drug, approved for use in thyroid cancer as well as kidney cancer in combination with Afinitor. Reasonably well tolerated drug. Again, early studies, small studies show activity, so we're taking it a step further, doing bigger studies with more patients to confirm that. Regorafenib, there isn't a whole lot of data with that right now. It's a drug called Stivarga used in colorectal cancer. Again, anti-angiogenic effect. Some studies are just getting started with that. It's a little bit of a tougher drug to take, but we'll see how it goes. Aflibercept is a drug that's very similar to Avastin, which I'm sure a lot of you guys have heard about. Again, affecting the blood supply to the tumor. Early clinical or preclinical data suggests that it may also play a role, may have activity as well. So that's another interesting compound that's being studied. So immunotherapy, it's sort of the buzzword these days. And I listed 4 drugs that are currently approved for use: pembrolizumab, Keytruda, nivolumab, which is Opdivo, atezolizumab, which is Tecentriq. I'm sure you see the advertisements on TV all the time. There isn't a whole lot of data right now with these drugs. There is, but there's reason to suspect that these agents may be active in more higher grade neuroendocrine tumors. They target something called PD-1 or PD-L1, and the expression of PD-1 and PD-L1 seems to be higher in higher grade neuroendocrine tumors. So that's sort of the draw. There is some data with pembrolizumab, Keytruda, and there's a trial going on in high-grade neuroendocrines. It may not be as effective as in lower-grade tumors, and I don't think we've started investigation on that, but high-grade neuroendocrines certainly appears to be promising. So molecular profiling. So what does this mean? So this is another big buzzword in oncology. So molecular profiling is sort of the personalized approach to cancer treatment. So what we do is we take cancer tissue, we send it to these labs, Foundation One or Caris are the 2 most popular ones, and they take the cancer tissue and they look for known biomarkers that we think are important in cancer development. So when we have this information, we can use these biomarkers that are specific for each individual and each individual's cancer, and we use that information to develop treatment protocols. So, for example, we can take a neuroendocrine cancer patient's tissue, send it for analysis, and we might find a biomarker that we see in breast cancer. And we could consider giving that patient a breast cancer treatment and see if it works. So that's sort of the approach. And there's 2 national trials that are ongoing that are doing just that, taking tissue, testing it for these biomarkers that are specific for the individual, and then seeing if there's a drug that targets their particular abnormality. So ASCO-TAPER is a trial that we actually have at Levine Cancer Institute that looks at that. And what's cool about both trials is that the drug companies have supplied us with their drugs for free so that patients can take them if they have a biomarker that the drug acts on. So, I mean, logically it makes sense, and it opens up a whole host of ideas and potential for future treatment. So I would encourage those patients who have stage 4 cancer and who don't have any active treatment options to get molecular profiling done through Caris or Foundation One, and we might find a biomarker that we can target with an investigational agent, either with these trials or some of the other trials drugs I'm going to discuss later. So it's a big deal. You know, these molecular profiling techniques are very expensive. Used to be very, very expensive, and insurance doesn't always pay for it. But nowadays, Foundation One and Caris have been very generous in helping patients to get this kind of testing done. I know at our institution we have a relationship with Caris, and they've told us that if we send them tissue, they won't bill a patient more than $550 for thousands of dollars worth of testing. So it's definitely something to consider. An NCI match is another national trial that's offered in other centers that does a very similar thing. So other compounds. So I picked out the ones that seemed a little more interesting to me. I went through all the trials listed on the NCI webpage. So ibrutinib is a Bruton tyrosine kinase inhibitor. It's an exciting drug that has changed how we treat a certain type of leukemia, chronic lymphocytic leukemia. It's also active in lymphoma. We think that the BTK pathway could potentially be important in neuroendocrine tumors. It's a very well-tolerated drug with minimal side effects. So there's a study that's opened, accruing patients. The preclinical data looks promising, but again, we haven't tested in patients, and it's certainly something that I'm excited about. LEE-011 is a CDK inhibitor, or another name for it is ribociclib. That drug is being given with everolimus or Afinitor. And why a CDK inhibitor? Well, we think that the CDK pathway is something that is important in neuroendocrine cancers, and targeting that pathway, you know, in the lab has been promising and looks to be something to certainly investigate further. And in general, these CDK inhibitors are, again, well tolerated, not significant side effects. Fosbredobulin is another drug with everolimus. I think Duke has that trial. Yeah. So, and the early phase studies with that show good disease control and very good tolerability. So. One of the things that I keep saying over and over again is that these are tolerable, well-tolerated drugs. This is not like some of the nasty stuff that's currently being used. Hate to bash Sutent and Afinitor, but they're tough drugs to take if any of you have been on. Next drug, X82, which is it is a VEGFR PDGFR inhibitor, again given with Afinitor in this trial. VEGFR is part of the angiogenic pathway. PDGFR is another biomarker that we can test for with the ASCO-TAPER NCI match trial. And if you do have PDGFR, a high expression of that, this drug could be a good candidate for treatment. SNX5422 is something called a heat shock protein 90 inhibitor. This class of drugs has been investigated in multiple tumor types. Again, preclinical lab data suggests it may be an important drug or a potentially effective drug in this disease process, and it's being investigated in an early phase study. The last two, I would say that I'm a little bit more excited about. The first one there, sulfatinib, targets VEGFR and something called FGFR, fibroblast growth factor receptor inhibitor. And some of their there's a phase 1 trial with that drug, and different tumor types, including neuroendocrine, and they had, I think, over 30 patients, over 30 neuroendocrine patients in that trial, in that phase 1 trial, and over 20% of them had disease shrinkage. Again, anytime we hear disease shrinking of the tumor in these diseases, we get excited. And 20% is pretty good. I think 9 out of however many showed shrinkage of the tumor, and others showed disease stability. So there's a bigger trial using that drug specifically in neuroendocrine tumors, and that's, I can't remember which center it's being offered at, but very, very exciting drug in my mind. Same thing with nintedanib. This is a sort of a dirty molecule, and I say dirty molecule because it targets many different things. It's not specific for one. So VEGFR, FGFR, PDGFR, it inhibits those pathways, which, like I mentioned before, could be important in this tumor type. And the early results on that drug are also pretty exciting. Again, with shrinkage of tumor in the lab, in the petri dishes, and also in humans. So, I mean, this is great. This is awesome. I mean, we couldn't 5 years ago. I could remember looking for trials, and I had a hard time finding even 3. So we got a lot out there. We may have to travel to these places, to different places to get to these sites. But, we got to accrue patients on these trials. That's the only way we're going to learn. So please, you guys, if you get to a point in your treatment where there aren't any good standard treatment options, or even before then, consider a clinical trial. This is how we get better. These are all promising drugs. 10 years ago or 13 years ago, whatever, when I was a fellow, there was a handful of drug trials. I'll tell you, none of them were very exciting to me. I would read the preclinical data and the early phase data, and I'm like, wow, why are we even wasting our time with these drugs? But these are promising drugs. And as we learn more about the science, the biology of neuroendocrine cancers, and again, we've made tons of progress over the past 10 years in that, we're able to develop clinical trials that make sense with drugs that logically make sense and are well tolerated. So I think it's an exciting time for research in these disease processes, and think about clinical trials. So big message is, and I hope this is a message that everybody gets from this conference, is there's a lot of reason for hope. Okay, we don't know what tomorrow will bring. When I see patients and I tell them that they have incurable cancer, I tell them, well, today, March 25th, 2017, we don't have a cure for stage 4 neuroendocrine cancer. But hang in there, hang around, and you don't know what tomorrow may bring. So, thank you.